Hi, I'm Gary Chimes from Lake Washington Sports and Spine in Bellevue, Washington, and we're going to be talking about the sports hernia complex. First of all, I use the term sports hernia complex because we're really dealing with a complex of different anatomic structures feeding into one another. One of the important things is that before you do this examination, have a conversation with the patient about discretion so they know that there's a reasonable likelihood that they may have exposure of their genitalia during the examination, but you want to make sure you do an appropriately thorough examination. In terms of exposing the patient appropriately, you're going to want to make sure that you can see the rectus abdominis musculature, the pubic tubercle, and the inner thigh. We recommend having the inner thigh positioned into the FABER position, flexion, abduction, and external rotation. We're going to take some gel, make sure to warm it to the extent that you can, or at least let the patient know that it may be cold, and then we're going to be applying that along the inner thigh. I'm going to be using a linear probe, and what we're looking at is the adductor or adductor musculature as we advance towards the pubic bone. So what we can see here is the tight fibrillar architecture of the adductor tendons, and depending on the plane, you can often see the different divisions of the adductor musculature between the adductor brevis, the adductor longus, and the adductor magnus. We're actually going to trace this all the way up to the pubic tubercle. Now we're seeing in this patient, we're looking at the left side of a male patient. And as we continue to advance, I'm going to rotate the probe, which right now is in the long axis of the adductor tendons, into a plane that is going to be a transverse view through the pubic symphysis. So here we can see on the left side of the screen is going to be the patient's right pubic tubercle. On the left side of the screen is going to be his left pubic tubercle. And then we can see the symphysis pubis. So one of the things is that in your differential diagnosis, you're going to often have a pubic symphysitis as part of the differential diagnosis. Sometimes you may see some cortical irregularity. This is a relatively young patient, so the cortical irregularity that we see here may be related to some of the cartilaginous growth plate in the region. Now I'm going to move out a little bit more laterally, so I am now looking at the patient's adductor. So we're going to be looking at the patient's adductor musculature. Going into the adductor tendon, going into the pubic tubercle. Now, when I want to look at a sports hernia, what I want to think about is how the rectus abdominis and the adductor longus are really essentially part of the same muscle. And to really understand that, what I'm going to do is now rotate to looking at the plane of the rectus abdominis. So I'm going to be rotating the probe into a long axis view on the rectus abdominis. As you can see, this is a study that really requires a wide exposure and copious gel if you want to do it properly. Okay, so what I'm going to be doing right now is tracing the adductor longus to the pubic tubercle and then upward into the rectus abdominis. So the way that the screen is set up right now is that proximal is to the left and distal is to the right. So I can see the adductor musculature, and at the top of the screen you can see the tight fibrillar architecture of the adductor tendons. Now, because of the rounded nature of the adductor tendons, sometimes it's easy to fall off, but I can see the tendons. I'm traveling more proximally, and eventually I'm going to be coming into view the pubic tubercle. Now, when you see there is some cortical irregularity that you can see in some planes. Sometimes that can be concerning about an injury to the common aponeurosis of the adductor longus and the superior pubic ramus. However, when I go over and I rotate and I look, there's a symmetry there. So this may be developmental, and that little gapping often has the characteristic gapping that you see when you see somebody who has some residual cartilaginous growth plate in that region. And this being a young patient, that's what I suspect. But you certainly take advantage to look for asymmetry, especially because a problem with the pubic symphysis itself is going to be a big part of your differential diagnosis. I'm now going to back off and rotate my probe, so I'm now in the long axis of the rectus abdominis. So the probe is, if you look, you can see the rectus abdominis muscle on the right, and it starts to taper into a tendinous insertion onto the superior pubic ramus. And the superior pubic ramus and the pubic tubercle is over in the middle of the screen. You see that bony acoustic landmark. And that's going to be that site of common aponeurosis between the superior pubic ramus and between the rectus abdominis and the adductor longus. Now, I'd like you to think about the adductor longus actually being a continuation of the rectus abdominis, and I want to show you what I mean by that. As I advance more proximally, I can see the gut moving underneath this rectus abdominis. That's him digesting lunch. And as I continue to advance upward, you're going to start seeing the interdigitations of the rectus abdominis muscle. So right there, we can see that interdigitation, that hyperechoic area between two portions of the rectus abdominis. Now I'm going to take a little time here to just explore the rectus abdominis and ask the patient to do a little bit of an abdominal crunch. And go upward, bring your shoulders off the table a little bit. Okay, and go back down, and let's do that again. Have you bring yourself up. I can see that muscle contracting and go back down. I'm now going to rotate the probe. So now I am looking at a short axis. So I'm looking at a cross section of the muscle. So you can look at the boundaries of the rectus abdominis. I'm actually looking right at the midline. So I can see the linea alba separating the two rectus abdomini muscles. Go ahead and do another stomach crunch. Go even more intense if you don't mind. I want to see those muscles really, there we go, and come back down. And then I can go out more laterally to see the linea semilunaris. So I can see the entire medial and lateral boundary of that rectus abdominis muscle. Now I'm going to rotate again. So now I'm on the long axis and I can see that interdigitation. And if I track that, I can go all the way up and see where the rectus abdominis muscle attaches to the ribs. I'm seeing the interdigitations there. So there's multiple interdigitations, and those interdigitations are what give the characteristic six-pack appearance of the rectus abdominis musculature. But you know what's even better than a six-pack? A seven-pack. And the rectus abdominis actually is a seven-pack muscle because as I continue to go more distally, I can see that rectus abdominis muscle attaching to the pubic tubercle, and then if I rotate the plane, I now am in a plane where I have the rectus abdominis to the left proximally, and I have the adductor longus on the right, which is going to be going down inferiorly. And as I continue to go down, boom, that's where the adductors come in. So what can happen is when you're having a sports hernia complex injury, it's a bit of a misnomer because it's not necessarily a hernia. It's to be an injury of anywhere along this complex between the adductor musculature, the adductor tendon, the superior pubic ramus or pubic tubercle, the pubic symphysis, and the rectus abdominis. So where can these injuries occur? So the most distal variant that we commonly see, and usually muscles do okay, although you can certainly see a hematoma formation in the muscle. But most commonly when you're going to get an injury of the sports hernia complex, it's going to be in the myotendinous junction of the groin musculature. So let's get a view there. So here on the screen, you can see that hyperechoic tendon on the left. You can see a little bit of the pubic tubercle, and you can see the muscle. Right at that junction point, you may see different examples of myotendinous junction injury. The one that would be the most acute would be a hematoma formation, where you may see some hypoechoic fluid developing between where the muscle and the tendon attach. You may also see classic tendinotic changes, such as focal thickening. You can lose some of the normal fibrillar architecture, or you may see a hypoechoic architecture. Certainly concordant pain would be an important detail, knowing whether you have pain or tenderness to palpation through the probe. You may see some cortical irregularities. You may see some lifting off of the bone. So in this plane right here, you can see relatively smooth bone, but in this plane, you see some cortical irregularity. And that cortical irregularity may be because of abnormal pull of either the adductor longus tendon or the rectus abdominis. As I come over here, now we're in the plane of the rectus abdominis. So the rectus abdominis is on your left, and that's more proximal, and then you have the superior pubic ramus and pubic tubercle. And what can happen is that tight fibrillar architecture overlying the pubic tubercle, you may find in that area that you'll see, again, the classic signs of tendinotic injury, where it might be hypoechoic, it may have an absence of normal fibrillar architecture, and then you can go into the rectus abdominis musculature. One of the things you want to do is take advantage of doing a dynamic exam. So let's just once more have you do a stomach crunch. I'm looking at where the rectus abdominis is attaching. Let's do that a few times and see if that reproduces the symptoms. Okay, now I'm going to go a little bit more distally. And what I'm going to do is I'm actually going to reach across, and then first I'm just going to passively try to push his tendon into adduction. I can also I can instruct the patient, can you push upward on my hand? And that's going to be really valuable, especially for like a myotendinous injury where you may see some gapping form between the muscle and the tendon. So go ahead and give that exertion again. Fantastic. So that's going to be the assessment for sports hernia complex injury using musculoskeletal ultrasound.